So today we are here with a practice test. It comprises of 25 MCQs, and let's discuss one by one. I also don't know the answer, so this is very honest test, let me tell you first thing. So let's start from section 1 about inflammatory bowel disease, and let's see the first question. Which lifestyle modification is identified as the most important factor in maintaining remission for a patient with Crohn's disease? And we have various options. Option A, adoption of a low fat diet. Option B, smoking cessation. Option C, daily low intensity exercise. And option D, regular use of probiotics. So we will break down each and every option and we'll see the best option. So let me add notes here too, so that we will be able to make notes at the same time of the answers. So first question. So first option is adoption of a low fat diet. Well, fats has nothing to do because it is one of the inflammatory condition. So in case of inflammation, we have to look for other options other than diet. Smoking cessation could be an option, is actually the best option according to me. Let's discuss option C, low intensity exercise. It has nothing to do with exercise because it's not related to obesity, it's not related to losing some fat or losing some weight. Option D is regular use of probiotics. So probiotics has good activity or good action for our gut health, but as far as inflammatory disease is concerned, I would recommend to select option B. Let's go for second MCQ regarding Crohn's disease. Which statement is correct concerning the risk of smoking? Crohn's disease, which statement is correct concerning the risk of smoking? So it means our question number one, there are some better chances that our question number one is correct. Smoking only affects the severity of symptoms, not the risk of development. So it says that it cannot cause the disease, rather it can worsen the disease. Let's see the option B. Smoking is associated with a 3 to 4 increased risk of developing the disease. So this option says there is increased risk if we are any patient is a smoker. Smoking reduces the risk. No, not at all. Smoking is contraindicated only during acute phase, so I would recommend to select option B. Then comes question number 3. Before initiating, okay, let me tell you one thing. I think the links available, let's click on the link. Smoking is associated, okay, also worse than its clinical. I think we are getting answers here too, so we can check answers. Okay, so B is correct of question number 2. Question number 1, we have to check the answer. Before starting treatment, stopping smoking is probably the most important factor. Yes, so option 1 is also question number 1 is also correct. So let's head towards question number 3. Before initiating immunosuppressive therapy for IBD, inflammatory bowel disease, which of the following must be considered? The patient's BMI and waist circumference? No. Presence of active or latent infections such as? Yes. Because in hepatitis you will see inflammation. In TB, especially extra pulmonary TB, there is inflammation, and in case of HIV there are some serious chances that disease may worsen or this can also help to develop IBD. So option B is correct according to me. Let's see option C, daily intake of dietary fiber. It's actually important if patient is suffering from constipation, and history of antacid use that we will discuss later on. So I think option B is correct. So let's see what is given at the end. Before starting treatment, this that suppresses immune function. Consider means yes. Anything that suppresses our immune system, that includes TB, hepatitis, and HIV diseases. So in these cases, there are some fair chances of developing IBD. Now let's head towards question number 4. A patient is diagnosed with mild to moderate ileal Crohn's disease. Which corticosteroid is preferred due to fewer adverse effects? So we have to select any of the corticosteroid, and that steroid should have least side effects possible, despite being less effective than systemic. Okay, so it is less effective as well. So which one is correct option? Less effective than systemic options. So here is another trick. It says less effective than systemic option. Here is a point. So it's not a systemic option. Prednisolone, we have tablets of prednisolone available, syrups available, ready paired. Hydrocortisone is available in ointment, in injection form, in cream form. Budesonide is available as an inhaled corticosteroid. Dexamethasone is also available in tablet form as well as in injection form. So hydrocortisone is also available in injection, so it can also cause systemic effects. So budesonide is, I think, could be the right choice. It was a little difficult, a little tricky, but let's see what does it suggest. Rectal corticosteroids are effective for distal colonic inflammation. Budesonide, yes. So budesonide is used. It is less effective than systemic. Next is question number 5. What is the significant? What is the significant clinical limitation of using azathioprine? Azathioprine or mercaptopurine for active IBD. Significant clinical limitation of using azathioprine or mercaptopurine for active IBD. Why can't we use azathioprine and or mercaptopurine? So they are ineffective for maintaining remission. Option B, onset of action may take up to 3 months. Option C, they are only available via parenteral administration. Or option D, they are contraindicated in patients with fistula. So I think it's option B. It's something like a guess, a wild guess actually. I'm not sure about it. I can't even discuss any of the options. So let's try option B, because I think it has, these drugs actually have delayed action. So let's see. Although onset of action may be up to 3 months, they may be used as adjunctive treatment in active. So yes, this is the right answer. So far we are going very well. In ulcerative colitis, now comes ulcerative colitis, not Crohn's disease, but ulcerative colitis. Which treatment is considered more effective than rectal corticosteroid for distal colitis? So if patient is suffering from distal colitis and you don't have to give rectal corticosteroids, what could be an effective treatment? Oral 5-amino salicylate, yes, it is one of the best option, and actually these drugs are reserved for ulcerative colitis. But let's see other. So rectal mesalazine, it is also One of the medicine that is used in such cases: oral methotrexate and oral prednisolone. All options are looking absolutely fine, but I would like to go with oral aminosalicylates. It could be mesalazine, it could be methotrexate or prednisolone, but I think 5-aminosalicylate is the one I think is reserved for such cases. So let's see. um, Option A. Let's see what does our content suggest. It says for distal okay, mesalazine is more effective than a rectal corticosteroid. So rectal mesalazine is the correct answer. So 3 was right, 4 was right, 5th was also right, but 6th is wrong. Let's put cross with red so that it will be visible. Here is okay. So next we have question number 7. Why are antidiarrheals like loperamide contraindicated in severe ulcerative colitis? You know one thing about antidiarrheals like loperamide, they are going to cause gastroparesis, or you can say they are going to decrease motility of gut. So risk of electrolyte imbalance, I don't think so. Risk of toxic megacolon, mm, or risk of intestinal obstruction, they interfere with 5-amino salicylate salicylic acid. So salicylic acid efficacy, I will go with option C because of side effect of loperamide. Option C. Seventh question. Sorry. Seventh question. Option C. And let's see the answer. Other treatment antidiarrheals, codeine, loperamide are contraindicated in severe disease because of the risk of. Okay, so toxic megacolon is the right answer. So this is also a wrong choice. So this is also wrong. So 7 is also wrong. Now let's come to question number 8. Which of the following is true regarding 5-aminosalicylate? Well, let me tell you very clearly, I don't have any information about 5-aminosalicylate, but let's solve it. In Crohn's disease, there is a gold standard for maintaining medically induced remission. A systemic review found them ineffective for maintaining medically induced remission. They are only used for severe refractory disease, or they are more effective than TNF alpha antagonist for fistula. Well, I've not considered option D, so we just get rid of option D. Gold standard can be for remission. Um, and what about option C? What do you think about it? They're only used for severe refractory disease. And what about option B? A systemic review found it's not ineffective. And this class is not ineffective. So option B and option D, I will cross these two options. And now option A and option C, these two remaining. It's not a gold standard. It can be gold standard, but for affected disease, I think 5 ASA, 5-aminosalicylate is not used. So I'm going to cross option C as well, and we'll go with option A. Let's see what does it say. Yes, used to induce remission in mild to moderate diseases. Okay, so it's not used in severe and refractory disease. So I was right. Efficacy in maintaining remission is controversial. A systemic review found. Okay, so it is ineffective for maintaining medically induced remission. So it's option B, not A. Wrong again. It's hat trick of wrong. answer. This is going to be difficult. So for me, difficulty level is increasing. I'm not sure about you guys. Let's discuss question number 9. In the context of pregnancy and IBD, what is the general recommendation for maintenance medication? In the context of pregnancy and IBD, what is the general recommendation for maintenance medication? Discontinue all medications immediately to protect the fetus. It says that all medicines are not safe. Maintenance medication should generally be continued to maintain disease control. Option C, switch all oral therapies to rectal formulations. And option D, only use corticosteroids during the third trimester. Corticosteroids are actually used in later on stages of pregnancy, but the purpose is different. Corticosteroids, according to me, can cross blood-brain, placenta very clearly, very easily. As a result, there will be side effects. There will be imbalance of electrolytes in fetus, and it can cause severe fetal damage. So option D shouldn't be selected at all costs, according to me. Again, I'm not sure about it, but according to me, option D is not the right choice. Option C, switch all oral therapies to rectal formulation. It is also possible just to reduce systemic side effects. Say, for example, if you are giving prednisolone rectally, PR, then it's going to decrease systemic effects and it will act much more locally. So it is one of the good choice. Maintenance medication should generally be continued to maintain disease control. So if any of the medicine is not functional, it is not showing activity, or it is causing more harm to fetus, then we can't continue that medication. So all maintenance medication shouldn't be continued. Discontinue, we can't discontinue because it can cause severe weight loss, it can cause severe pain to the patient. So I will stick with option C, and let's see if I give four answers wrongly in a row or not. So let's observe the answer. Yes. It is important to maintain adequate disease control for both maternal and fetal health. Maintenance medication should generally be continued. So it's option B. So four questions wrong in a row. I'm not good at it. Okay, let's see if I can make a comeback or not. Which probiotic has evidence? Okay, this is very simple. For helping maintain remission in chronic or refractory pouchitis, it's Lactobacillus GG. We are also dealing with it, so it's option A. Little. Oh no, VSL3. No way. We've been using GG. Six specialist. Oh my god. Another wrong answer. It's five in a row. I am just nailing it. Oh my god, I'm gonna fail exam. Let's come to obesity and weight management. Out of 10, my 5 answers are wrong and 5 are correct. So it's 50% result, it's not a good result at all. Let's discuss section 2, obesity and weight management. Hopefully I will do good in this. Which measurement provides an estimate of adiposity in adults but is less useful in the elderly or very fit individuals? Okay, so it looks very simple, very straightforward, but it has small deviation, that is abdominal circumference and waist to hip ratio. So say for example, I will consider one of the practical example. If someone is not having too much belly fat, but looks very bulky, and he's not masculine. He's not possessing huge muscles, so he's having fats. In that case, waist to hip ratio could be one of the factor. But option C, at the same time, abdominal circumference, it can also mislead. So I would recommend waist to hip ratio. Yes, waist to hip ratio, because it can give us false results. So let's go with option A. So we are in section 2 now. For 11th question, I think it's A. BMI. It is less useful in the elderly and in very fit and must. Oh my god, how can I? If patient having BMI of 30, we can't. Oh, that was easy. That was very easy. You see, I didn't get it. It was easy. Let me tell you how. Now I have one logic to explain. If a person is very healthy, he has big muscles, still his BMI will is lying in between 25 and 30 or more than 30, just because he has good muscles. So he has muscles, not fats. So it means if he is carrying high weight value, then it means it's healthy weight, not unhealthy weight. He's not carrying any fats, right? So that's why my question 11 is wrong. More devastation. Okay. Hopefully you are giving right answers. According to BMI classification, a person is considered obese. Ah, this one is simple. Okay, so there are two categories: above 25.9 BMI. If patient is in between 25.9 to 30, then patient is overweight. And if patient is having BMI more than 30, means 31 and plus, then patient is actually obese. So it's C. It was simple. It was very simple. You can say that I have answers of simple questions, not of difficult ones. What is the recommended fat intake percentage for an adult starting a lifestyle modification program for weight loss? What is the recommended fat intake percentage? Um, for an adult starting a lifestyle modification, I think it's less than 20, less than 10%. I'm not sure, but um, it's a guess, but upon some on the basis of some background knowledge, it is, I think, a less than 10% of total calories. Let's see answer. Oh, it's 30%. Oh my god. Another wrong guess. Another wrong answer. I'm just needing it. I started very well. Now I'm finishing it, or I'm in the middle. I'm lost. Which weight loss medication? Weight loss medication prevents the absorption of. Okay, it's very simple. It's Orlistat. See, I'm not that much bad in it. It's option C, and this is the only option that is correct. Orlistat. Why is the use of thyroxine for weight reduction control? Oh, okay, it's very simple because it increases metabolic rate. So it comes with the multiple complication that includes arrhythmia and bone disease. So it's option B. 15, option B. It looks like I'm making a comeback now. Wait, it's 15. Yes, metabolic rate can due to metabolic complications, which with excess thyroxine like arrhythmias, hypertension, and bone disease. Option 16, question 16, in children and adolescent, what BMI percentile indicates obesity? Oh my god, I haven't heard of it. This question. BMI percentile indicates obesity more than 50%, more than 75%, more than 85%, or more than 95 percentile. Mm-hmm. It's again going to be my wild guess experience. it that's not been so good. You can see red cross all around. So I will say it's 50%. Eh? It's just a normal guess without any background knowledge. Okay, BMI 85th percentile indicates overweight. 95 indicates obesity. So it's 95. It's option D. Which statement regarding weight loss goals is accurate according to clinical guidelines? Which statement regarding weight loss goals is accurate according to clinical guidelines? Only a 20% weight loss provides significant health benefits? Nope. A weight loss of 5 to 10% of initial weight has significant health benefits. Drug treatment is the first. No, not at all. Drug treatment is not first choice. It's not a first step. Okay. Absolute weight loss is the only valid marker of success. No, not at all. You know one thing, if you are obese and giving 15 minutes to exercise to just get rid of some fats over your body, then you're doing great job. Okay, that's one of the recommended guideline. At least you should do exercise for 15 minutes a day, and 15 minutes is not that much high number, I reckon. So only a 20% weight loss provides significant weight benefits, health benefits, sorry. And option B, a weight loss of 5 to 10% of initial weight has significant health benefit. So yeah, it's not always like like this way. That if a person tries to lose all weight, becoming frail, then of course there'll be some serious chances of having health conditions. So it could be B. Again, it's one of my guess. So option 17, I would say it's B, because it can cause good significant health benefits. Just only word in option A is putting me in confusion. Let's see. Yes, it is right. Programs, including those that involve drug treatment, resulting in weight loss of the order of 5 to 10% of initial weight, have significant health benefits, although they may not meet the individual's desired weight loss. But remember one thing, weight loss with the help of drug treatment is not always first step. It comes later. First of all, diet management is the criteria to be followed. Then comes section 3. Okay, just two. Oh no, three answers are wrong. Out of one, two, three, four, five, six, seven. Out of seven, three are wrong. Four are correct. Again, almost 50% result. What is the recommended maximum? Oh, it is about perianal disorders. What is the recommended maximum duration for using topical anesthetics? Oh yeah, this is very important. Uh, Remember one thing: anesthetics are going to increase sensitivity of the area, and perianal area is actually very sensitive already. By use of local anesthetic, it can become more sensitive. And if patient is using corticosteroids, local corticosteroids are topical corticosteroids, then there are some serious chances of developing inflammatory diseases or infectious diseases there. Not inflammatory, but infectious diseases. Fungal infection, bacterial infection, any kind of infection can happen at that place, and it will be very devastating for the patient. So it should be, you can say, less than 7 days. Why? I have told you the reason. So um, it's 7 days. B. Yes, less than 7 days, as I have told you, it's going to make the skin sensitive, and topical steroids are going to increase chances of infection. So next question is question number 19. This one is true. Question number 19. Which treatment is indicated to relieve pain associated with chronic anal fissures and assist in healing? So glyceryl trinitrate also helps to reduce pain. There is no option of anesthesia, local anesthetics. Oral loperamide is not an option. Topical antibiotics, no. High dose corticosteroids, no. So it's rectal glyceryl trinitrate, GTN cream. Oral paracetamol may help relieve prolonged burning pain after defecation. Rectal glyceryl trinitrate relieves pain associated with chronic inefficiency. So option B is correct choice. Question number 20. What is the common side effect of rectal glyceryl trinitrate? Okay, so its major side effect is headache. It's option C. You know how glyceryl trinitrate works. It is actually vasodilator, especially venodilator, means it dilates veins. As a result, it is going to reduce blood pressure. That's not an option available. So it's going to cause headache. Question number 21. So 19 and 20 are correct. Question number 21. What is the best way to avoid drug interactions between antacids and other oral medications? Simply take them apart. If you're using antacids and other medicines that have strong interaction in between, say for example, iron is one of the supplement that shows interaction with antacids. You have doxycycline, other tetracyclines like tetracycline itself. It has interaction also. Alendronate has an interaction with the multivalent cations. So those drugs should be taken with the interval of 2 hours. So take them simultaneously with a large glass of water. No, not at all. Separate administration by at least 2 hours. Okay, and only use liquid antacids or take antacids only on an empty stomach. So remember one thing: high efficacy of antacids can only achieved after 1 to 2 hours of meal. Okay, so you have to take antacids after food, but make sure to take it after 1 hour or 2 hours. And if there are chances of drug interaction, then you have to apart the dose of antacids 2 hours from that interacting drug. So it's B. That is correct. Option 22. Antacids containing which elements should be avoided are used with extreme caution in patients with. Okay, so it's creat clearance 10 ml per minute. So it means it is one of the safest drug in renal impairment, because creat clearance less than 10 is actually a huge thing, you can say huge margin. Bismuth subsalicylate is usually contraindicated in patients having creat clearance of less than 30. But this specific drug, that is, I think, yeah, aluminium, calcium, and magnesium, because already renal compromised patient is suffering from electrolyte imbalance. That's why if patient is having creat clearance of 10 ml per minute or less than this one, in those patients aluminium, magnesium, and calcium should be discouraged to be administered. So it's option B. What about 23rd? Which adverse effect is commonly associated with antacids containing aluminium or calcium? Good question. Diarrhea is actually associated with magnesium. Magnesium is insoluble cation, multivalent cation, and that's why magnesium leads to diarrhea. While aluminium and calcium both are associated with constipation. Hypertension, calcium can cause hypertension in high doses, but not the aluminium. Weight gain is the property of none. So B is the right answer. Oh, we haven't been checking answers. So sorry. I am actually sure about these. C, aluminum, calcium, magnesium. And then of question number 21, it's B. Best way to avoid, yeah, 2 hours. Question number 23 is B, constipation. Question number 24. I'm sure about these, so that's why I forgot to check the answers. Question number 24. What is the mode of action for sucralfate? Oh, it's very simple. It forms a protective layer over the peptic ulcer site. Neutralizes? No. Antacids are the drugs which actually neutralize hydrochloric acid. It includes magnesium hydroxide, magnesium trisilicate, aluminum hydroxide, calcium carbonate, sodium alginate. Okay, and sometimes simethicone is also considered as one of the antacid, but actually it is less effective as antacid. Rather, it is used to treat flatulence. What is the mode of action for sucralfate? I told you it's not option A, it's option B. Actually, it forms a protective layer, and let me tell you one thing: it also carries anti-inflammatory property, antibacterial property against H. pylori. So here both options are available, but we will select option B because it's much more effective in this way. So let's see what does it say. Press points: bismuth can accumulate and cause toxicity with excessive doses or a prolonged course of more than 2 months. Sucralfate for drug interaction. C, sucralfate mode of action forms a protective barrier at the ulcer site, resistance to acid, pepsin, and bile. So yes, 24, option B is correct. Question number 25, that's the last question. When is the optimum time to, yes, optimum time, I have told you before, I told you 1 to 2 hours, so it's 1 to 3 hours after meal. Sorry if I made a mistake. So it's option C, and it's correct. So here will be some answers given. B, then C, it's right, then fifth B, 6B, that's wrong, then C, that's wrong, 8th B, 9B wrong, 10B wrong, 11B wrong, 12C that's right, 13B wrong, 14 is C right, 15B right, 16D wrong, 17, and after that 17 B, oh no, one of my answer is wrong. 17 is right, 18 is right, 19 is wrong. Rectal glycerol relieves pain and has a modest effect on healing. So Yeah, this is answer. I think I have selected wrong option. Let's see option question number 19. Oh, it's option A. Oh my god. So it will be considered wrong. So this is wrong. Okay, so another wrong. Another added into tally. 21 is B, then B, 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 and C. So 1, 2, 3, 4, 5, 6, 7, 8, and 9 are wrong. So 25 minus 9, it will be 16. So 16 out of 25. Not a good result because there was a streak of wrong answers, but hopefully we will be doing very better in upcoming MCQs. We will try to repeat this activity very often. Thank you so much for your time. We'll see you with another list of MCQs related to CAOP Fiji exam in the next video. Till then, take care. Bye.